MCH. So when we are talking about revascularization in PADs, we have to know what PAD actually is. So basically it is chronic atherosclerotic occlusive vascular disease of the lower extremities. It has a very high disease burden presently in the world, and the latest data presents that more than 200 million people worldwide are affected with PADs. And we have to keep in mind that because most of the centers do not assess for asymptomatic patients, they don't do ABPI routinely, and they don't go for atherosclerotic screening. So there is a large burden of PAD that is asymptomatic. And the numbers are on an increase. The last decade, about 25% increase in prevalence has been seen in most of the studies. It affects both high income and low income regions. And the risk factors are same as for atherosclerosis. As Sir said, they can be modifiable and non-modifiable. Age is definitely a factor. Most of the patients who present with atherosclerotic PADs are more than 40 or in the late 50s. Then smoking is the one of the major risk factors, and most of the patients that we operate upon, they have been smokers or are presently smoking. Diabetes cannot be understated. Hypertension, dyslipidemia, obesity, the clear-cut correlation has not been established. Some people have suggested a U-shaped curve because frailty is also a risk factor for PADs. But nonetheless, obesity has been implicated in atherosclerosis, and we regard it as a risk factor for PAD. And then there are other factors like homocysteine levels, ethnicity, and socioeconomic status, and so on. So, for the purpose of management of PAD, there are many classifications have been suggested, namely the Rutherford, Fontaine, and there are many extensive classifications. But basically, as surgeons, as vascular surgeons, as cardiovascular surgeons, we use two classifications: the anatomical distribution and the clinical syndrome of presentation. So, as we can see the anatomical distribution here, you can see normal vasculature. This is the abdominal aorta that is dividing into the common iliac, that is further going in to become the external iliac and the internal iliac. The external iliac, as we all know from our MBBS days, continues as the CFA or the common femoral, which in the thigh bifurcates into the profunda femoris or the deep femoral, and continues as a superficial femoral, which after the canal becomes the popliteal artery. Then we go, this is the knee crease, and it becomes infrageniculate and trifurcates into the tibioperoneal trunk and the anteriotibial artery, and the tibioperoneal trunk finally bifurcates into the peroneum and the PTA. That is knowledge we have from our anatomy classes. So basically, the atherosclerotic disease has an anatomic distribution. It can be suprainguinal or the aortoiliac disease that involves the aorta and the common iliacs and the external iliacs. Then there is infrainguinal region, which involves the femoropopliteal, that is above the canal, and then the infrainguinal, the infrageniculate or the tibiopedal disease. So that is important from the management point of view, because as we go up, the role of the surgeon and the interventional radiologist in revascularization increases. As Dr. Modi has rightly pointed out, that if the large vessels are not right, we cannot go in for any interventions in the small vessels, and vice versa. So as we go down, the role of revascularization comes down, surgical revascularization or stenting comes down, and as we go up, there is more and more role of surgical revascularization. Then the management is much more dependent on how the patient is presenting. The patient can be asymptomatic. That is usually a coincidental finding in our setups. The patient gets a CT abdomen done, and we find atherosclerotic disease in aorta, and we further evaluate. Or in some clinics, there's ABPI measurements in patients of diabetes and atherosclerosis to identify latent PADs. Then there can be intermittent claudication, which is nothing but reproducible leg pain with exercise, which is relieved on rest. And then finally, the clinical syndrome of critical limb ischemia, which includes rest pain, that is pain even without exercise and not relieved on rest, and tissue defects, which may include gangrenes and non-healing ulcers. So this critical limb ischemia is a very severe form of PAD, and it represents that the baseline supply, the blood supply of the limb has now become inadequate to maintain tissue perfusion. And some form of revascularization is mandated in some patients. So I'll be dealing with critical limb ischemia basically for the purpose of revascularization. So in any patient of critical limb ischemia with rest pain or tissue defect, we have to go in for medical management definitely, which includes risk factor modification. Diabetes has to be aggressively controlled, hypertension has to be controlled, we have to avoid beta blockers and other diseases that may enhance PADs. Smoking cessation, there is no if and but, as sir told. And if there is proven dyslipidemia, we may require statins and then graded exercises. For the purpose of pharmacotherapy, only two drugs are certified to be used. Aspirin, a single antiplatelet. If aspirin is not tolerated, we may go in for clopidogrel or other antiplatelets. And cilostazol, which is basically a phosphodiesterase inhibitor that prevents smooth muscle cell contraction and platelet aggregation and multiple methods of working, which basically improves microvasculature. These are the only two drugs. Earlier we were using pentoxifylline or Trental in common language and this other drugs, but the evidence is only for aspirin and SABT. Painkillers if required. Usually avoid NSAIDs as there may be coexisting renal disease, and some role of methylcobalamin and folate, if particularly if neuropathy is there. So, if the patient is having critical ischemia, there is definite evidence that medical management alone, when compared with medical management with revascularization, there is a benefit of revascularization in the patient outcomes, wound healing as well as longevity. And if we are talking about revascularization, we have basically two options in the present era: endovascular and open surgical. And if we talk about the merits of both and the cons of both, we know that endovascular, there is less procedural risk, there is minimal invasive, it's less invasive as compared to surgery. We don't give the patient any form of anesthesia, and usually it's done under local or minimal sedation. So definitely, when endovascular procedure is never feasible, we try to go in for endovascular procedures because of the low risk involved. And but the only thing is that the procedures are usually not that long-lasting as compared to surgery. So in young patients, in patients in whom there is a long segment disease, as we'll talk in the further slides, endovascular is not an option, and then we have to go for open surgical procedures. But when and where we can go in for endovascular procedure in the present surgical practice, we should opt for endovascular procedures, which may be done either by a surgeon or an interventional radiologist. It's a gray area in the present day. So, to basically objectify the management of the choice of endovascular versus surgical procedures, a consensus was formed, which is the Transatlantic Inter-Society Consensus between the multiple societies, and they basically divided they have two classifications, one for the aortofemoral aortoiliac disease and one for the femoropopliteal or the infrainguinal disease, and they have classified the lesions into task A, B, C and D in both the groups. So it's a very extensive, and we don't need to go into details. The basic idea is that type A lesions are small lesions. They are discrete, small, involving not involving a long segment, while the D on the other extreme are long segment involving bifurcations, tight lesions, and the B and C are intermediate. So basically the idea is that type A lesions, we have to go for endovascular because they are small lesions, discrete lesions. Type D, we have to go for surgery. Type B and C, they are gray areas depending on the institutional policies and the institutional expertise and individual patient decision. We may opt for either endovascular or surgical procedures. But the thing that we have to keep in mind is that this classification was made in 2007. They have come up with some updates in 2015, but the the third guidelines are still awaited. And the endovascular procedures have undergone a lot of improvement in these around almost 20 years, and many of the type D lesions at many centers are now being treated by endovascular procedures. But that is then to be decided on a lot of many factors. So the one drawback of this task classification is that it doesn't take into account many other factors that come into play when we are treating a patient. It just talks about the lesion on CT. So we don't talk about the age of the patient. A very old age patient, a discrete lesion, and we go for our extensive surgery, we may not tolerate that. Comorbidities, a patient is diabetic, a florid diabetic, and we go in for surgery, the graft gets infected, we may actually cause more harm. The functional status and mobility of the patient is having neuropathy, is not able to move some orthopedic component, we don't go for extensive procedures in some patients. The clinical extent and the extent of sepsis in the patient, that is also very important. And finally, conduit availability. In many surgical procedures, we use saphenous veins and other conduits. And in our patients particularly, the Indian population, we have seen that many may not have adequate veins. So if such is not possible, then we may have to opt for endovascular procedures. So as I was talking about the clinical extent, as you can see, these are the various patients of PAD who are all having critical limb ischemia, that is tissue defect. But the extent of tissue defect is quite different. You can see a small wound here, almost both the feet are involved in this one, a part of foot is involved, and I have not put many pictures, but we all know that we can get patients who have all of the lower limb involved in the first presentation because of the, as I was saying, that the access is very bad to healthcare in our condition or for socioeconomic status. The patients don't report timely and they report in such a condition that whole of the leg or even up to the half of the calf is gangrenous. So we have to take into account the present condition of the patient, the clinical extent of the lesion, not just the CT films. So for that, at our center and many centers, we have made an algorithm which is basically a guiding light for decision making in any patient presenting with tissue defect and PAD. So this is a very simple algorithm. First of all, when a patient presents, we go for wound assessment and the assessment of the general condition of the patient. If the patient is having a very high septic load or a very extensive gangrene, then if it's not the case and he's having only a very small lesion, then we go for a CT. If the patient is having a very high septic load and extensive gangrene, then we go for aggressive wound debridement or primary amputation, depending on how the wound is and how we discuss it with the family, and definitely aggressive medical management, including control of diabetes, hypertension, and other comorbidities. Now, if we get a good wound healing and the stump is healing well, we don't do much because the part that was dead, we have already taken it out, and maybe the blood supply that is coming to the wound is to the limb is adequate for the remaining part, and we continue on aggressive medical management, smoking cessation, and local wound care as required. But in cases in which the stump is not healing, or in cases in which at the first presentation the wound was not extensive, we can go for revascularization. Now, we have two types of patients, that is the ones who are primarily presenting with a small wound, or in those in which we have done wound debridement or amputation, but the stump is not healing. Now we have to think of revascularization. So we go in for a CT, which is the cornerstone of our diagnosis and management. And if the CT anatomy is favorable for endovascular procedure, we push for endovascular procedure. We talk to our interventional radiologist. We have a combined cath lab and we go in for endovascular procedures. In case the CT anatomy is not favorable, which I have seen in most of the cases presenting late is not, and they are task D lesions, we assess the patient for the surgical candidacy. We go for a coronary angiogram in all patients, an echo, a general condition assessment, assessment of mobility, and other anesthetic checkups. If it is all favorable, the patient is young, he can take up surgery, we go for surgical revascularization. If the patient is not fit for surgery, then we have to stick to medical management and even more debridement of the wound as required. So this is the basic algorithm, and we have to individualize it to each patient and have a team decision. So talking about CT films, I'll just show some CT films of lesions that we are treating surgically. So these are mostly task D lesions. As you can see here, this is aortoiliac disease, a complete cutoff. A stent won't pass, the guide wire won't go in most situations, and we'll opt for surgical revascularization if the patient is fit. Here also you can see there is almost a complete cutoff in the right aortoiliac system, and this is a lesion that I'll treat with surgery. This is a classical aortobiliac lesion. There is cutoff on both sides from the inferior aorta, and also the patient has right infrapopliteal disease. So the patient will require definitely surgical revascularization. Here also the patient is having aortobiliac disease with extensive calcification. Stenting won't be possible. And even if we put a stent, it will get blocked in 2 to 3 months or maximum 6 months. This is a aortoiliac disease plus a femoral-popliteal disease. Here you can see two multi-level occlusion. This is a femoral-popliteal, left femoral-popliteal. This is a bilateral femoral-popliteal disease. And finally, we have an example of infragenucleate or popliteal disease. The trifurcation is seen, and then there is no continuity between the trifurcation and the distal population. So, when we decide for open surgical revascularization, what are the options? Just briefly, I'll talk about the anatomical bypasses, which follow the actual route of the vessel, and then there are the extra anatomical bypasses. The anatomical bypasses, they involve aortofemoral, aortobifemoral, aortoiliac, fempop, and popliteal bypasses. There are some extra anatomical bypasses like axillobifemoral bypass. Like recently in a patient, we opened up for aortobifemoral bypass. He had a large splenic abscess, previously not seen on the CT. So we could not put a graft inside the abdomen because it may get infected, and we had to take up axillobifemoral bypass. A FemFem bypass is a good option in very old candidates who cannot undergo general CCI and would not tolerate opening of the abdomen. So it's extra anatomical, and we take the proximal from the healthy femoral and put it on the distal femoral, distal on the diseased femoral, the pontolateral side. Graphical representation, this is the aortobifemoral bypass. The red is the bypass that we do. This is the femoral-popliteal bypass. If we go hair to hair, if you can see my cursor, this is the popliteal bypass, and this is the femoral bypass, which is an extra anatomical bypass that I was talking about. The conduits, suprainguinal, we usually prefer prosthetic conduit. Infrainguinal, if it is above the knee, we can either go for prosthetic or for a vein. Vein is definitely better, but we may not get a good vein in all the patients. And if it is below the knee, definitely we have to go for a vein, because very small prosthetic graft below the knee will definitely get obstructed very soon. I will just show some videos and then so this is the aortoiliac disease, as you can see, and this is the abdomen has been opened. You can see this is the abdominal aorta, this is the right iliac, the bifurcation, the left iliac must be somewhere here. And we have taken our proximal from this aortoiliac bifurcation, and it will be tunneled retroperitoneally, as you will just see. It was tunneled retroperitoneally. This is the abdomen, and we'll go down. This is the femoral that has been exposed, and the distal, as you can see here. The distal has been put on the profunda, the superficial femoral. This is another aortoiliac bypass. Again, you can see this is the aorta. Aortoiliac bifurcation in the abdomen, the bowel has been retracted, and the PTFE graft has been tunneled retroperitoneally, and it will be reaching, I think, the right femoral. This is the right femoral, and with healthy pulsations, if you can see. And this is the distal part of the graft. This is one more case. This aortofem with the femoral-popliteal multi-segment occlusion was seen, as you can see in the CT. I showed that CT earlier. And this is the very beautifully visualized aortic bifurcation. We did an endarterectomy on the left side, and we took a graft from that side, and we came to the right femoral. We can see both the abdomen opened and the femorals, the right femoral opened up. And if we go down, this is the right femoral. And then we took another graft from the right femoral and tunneled it under the subcutaneous tissue of the knee, of the thigh. And this is finally, we have landed just above the knee, the distal popliteal. This is a popliteal bypass. This is basically the thigh has been opened, and you can see this is the vein, saphenous vein, that has been taken from the leg, and from the popliteal artery, the vein is going, and it will cross the knee. As you will see, it's pulsating. I don't know if it's visible, the pulsations are visible on that. And it goes onto the posterior tibial artery below the knee. We have done a popliteal endarterectomy in one of the cases. So this was the atherosclerotic plaque that we had taken out. And finally, this was one case. So this patient had basically aortoiliac disease along with mesenteric ischemia. The SMA was occluded, which was not amenable to stenting. So we did a aortofemoral bypass. This is the Y graft. a 1266 Y graft. This is the right Y, this is the left limb of the Y going below. And this is, we have taken a retrograde ring graft to the SMA for the SMA syndrome. So the patient was having both claudication with tissue defect and was also having severe postprandial pain and weight loss. So we bypassed this aortoiliac, and from that graft only we took another graft, piggybacked it, and to the SMA here. So this is the SMA on which we have implanted, and lower down we have the femoral outflows. So finally, the take-home message: revascularization is the cornerstone of therapy in critical limb ischemia. That is without doubt. And we have to take a multidisciplinary approach, as we have been emphasizing throughout this conference. And a team decision has to be made between an endocrinologist, a surgeon, and interventional radiologist, and even an orthopedician if required. And the treatment has to be individualized, because a technically successful procedure may not always convert into better clinical results in any case of PAD. And that has to be kept in mind. We have to individualize it depending on the type of the lesion, as well as the patient's comorbidities and the functional status. Thank you.
Thank you very much, Dr. Shamal, for such a lucid presentation. If there are any questions from the audience, you can take that. If not, thank you.
Yes, thank you.
I have a query.
Yes, sir.
Regarding this SMA artery syndrome, Wilkie syndrome, so at what level of the disease point you are opting for this grafting procedure?
Sir, anatomical level or the clinical level of the patient?
Clinical.
Sir, basically that was we discussed with our GI team. So when we reviewed the CT, his celiac and IMA was thrombosed and celiac was totally blocked. And SMA, we always try to get the SMA stented if the patient is having symptoms. But there was a long segment block which was not amenable to stenting, and the patient was having severe weight loss and postprandial pain. So usually we try to avoid doing SMA bypasses whenever we get such patients, and we refer them to our GI surgery colleagues for further management. But he was not responding to the conventional management, and the patient was having significant weight loss and almost totally inability to eat food. He was almost afraid of food. So we have done two SMA bypasses. We really don't get very aggressive to treat the SMA syndrome surgically. But still, we have nonetheless done two bypasses, and we always involve our gastro colleagues with us.
Yes, because our opinion or our thought is something different.
Exactly. So it's totally the prerogative of the GI team. If they ask us to operate, they usually do the exposure for SMA, and we just put the graft. And in this case, there was aortoiliac bypass also, so we had to do it in our OT. But usually we go to their OT and just do the bypass. They do all the exposures. We do the aortic exposure and the grafting. But the decision to operate is to be taken by the general surgeon or the gastro surgeon. That's not our domain, and we accept that definitely.
Okay, and the second question is, what about the pain after the critical limb ischemia? You are opting for the grafting procedure.
Usually it gets released on the day one. Definitely it gets relieved. In patients who are having rest pain or intermittent claudication, definitely the results are very good. By the night they are comfortable. But in patients who have had tissue defects, usually they are the ones who don't respond very well. Some part of their foot may still remain painful. Usually the part that is involved in the tissue or the tissue defect or the part around it, even after the procedure. So we explain to the patient very clearly before the surgery that we are operating to save the rest of the limb, and they may have to go in for amputations even after the surgery. And patients who have good healing after the surgery but their pain is not responding, we send them to the pain clinic for nerve blocks. So they respond well to nerve blocks and gabapentin. Usually we start gabapentin and before going for any nerve block. But if the patient is not responding even after revascularization and tissue healing, then we go for nerve blocks. If after revascularization the tissue is not improving and he's still having pain, then we may have to revise our amputation or go for extensive repair. That we have to explain preoperatively. So counseling is very important preoperatively, so the patient has an idea what he is going into.
Okay, thank you.
Thank you.
Any query from the audience?
Thanks.
एक भी कोई Thank you so much, sir, for your valuable thoughts and insights. In the next section, we would be discussing post-traumatic wound management. And to chair the session, I would like to invite Dr. Som Prakash Basu, sir, Dr. Imran Ahmed, sir, and Dr. Abbas, sir.